Hello, everyone, and thank you for joining this special webinar honoring the winners of the 2020 Andrew J. Lockhart Memorial Prize, Dr. Matt Bucknor and Dr. Pejman Ghanouni. This $75,000 prize is awarded annually to investigators in recognition of their outstanding contributions in advancing cancer treatment using focused ultrasound and their potential for continued achievements in the field. Matt Bucknor is Associate Professor of Radiology at the University of California, San Francisco, and also the Director of Focused Ultrasound at UCSF. Pejman Ghanouni is Assistant Professor of Radiology at Stanford University, and he leads Stanford's Minimally Invasive MR Interventional Center and co-directs Stanford's Focused Ultrasound Center of Excellence. The Lockhart Prize was established in 2017 by the family and friends of Andrew Lockhart, who passed away in 2016 at the age of 39 after a hard-fought battle with cholangiocarcinoma, an aggressive malignant cancer affecting the biliary system. In a break from tradition, the foundation chose to award two prizes this year: Matt and Pejman's active collaboration and passion for the treatment of intractable cancers, coupled with their particular interest in immune-based focused ultrasound treatments, made them both equally deserving of the award. Today, we'll hear from both Matt and Pejman about key highlights from their current research. Before we get started with the presentations, a few technical items. If your connection is lost, please simply log in again through the link you received when you registered. You will receive a link to a recording of the webinar as well. And if you'd like to ask a question, please submit it at any time via the Q&A function at the bottom of your screen. We will collect these questions until the Q&A period at the end of the presentation. And now I'd like to introduce Dr. Matt Bucknor and Dr. Pejman Ghanouni. Matt, the floor is yours.
Thanks so much, Jessica, for that kind introduction. It's a privilege to be with everyone out there today. Good morning, good afternoon, good night, wherever you are. And I'm going to talk a little bit about this really exciting concept, I think, in the world of focused ultrasound, which is the idea of using adjuvant focused ultrasound to promote immune response. And I'll be focusing my comments to the context of soft tissue tumors and one sarcoma in particular. I have nothing to disclose. Before I get started, I just want to say a heartfelt thank you, first to the Lockhart family for sponsoring this incredibly generous award. And then second, of course, to the Focused Ultrasound Foundation, which has just been such a tremendous force for connecting scientists and researchers in this really growing, exciting field. And I hope all of you are signed up for the symposium next week as well. So I'll give a little bit of brief background on focused ultrasound. I know we might have folks of different levels of familiarity with the technology, and then talk a little bit about this interesting case I had of the disappearing desmoid tumor and how that sort of led me to think more about the potential immune response effects of focused ultrasound. And then we'll wrap up. I'll give an overview of an exciting new research clinical trial that we're starting at UCSF, a feasibility study exploring these immune response effects in the setting of a particular soft tissue sarcoma. So this is the focused ultrasound device that we use for all of our treatments at UCSF. It's the Insightec Exablate device, the only MRI-guided focused ultrasound device that we're using. And you can see that it has this large power cord that's going to the center of the table, where there's a translucent window where the ultrasound transducer lives. The common analogy for how this technology works is it's a lot like a magnifying glass focusing sunlight to generate heat at a single point. You can do the same thing with a focused ultrasound transducer. So we have a phased array transducer that's embedded within an MRI table that puts out focused sound waves and generates heat at a single point, quite hot, 75 to 85 degrees Celsius in about 20 seconds. So one of the most common indications that we are treating at UCSF are patients who have a specific soft tissue tumor known as a desmoid tumor. These are benign, locally aggressive soft tissue tumors that are derived from fibroblasts. They can be sporadic or familial. I'd say probably in the vast majority of cases, they seem to be sporadic and associated with a vague history of trauma. And despite different conventional treatments like surgery, radiation, chemotherapy, there are high levels of recurrence, and these existing strategies don't seem to work very well for many patients. So there's a real need to kind of find new solutions. So here's an example just to give you a sense of what we try to do with these tumors. We have this 7-year-old boy who has this large desmoid tumor in the anterior compartment of his thigh. So this is an axial MRI image. It's a T2 fat saturated image. You can see this large tumor in the region of the quadriceps musculature. It's a little bit heterogeneous in appearance. There are some areas that look darker and are a little bit more linear. Those are probably some septations that are dividing up some of the lobules of the tumor. And the rest of it is quite bright on this particular sequence. And then we see here we have a coronal image. So here's his right leg and his left leg, and the pelvis is up here. You can see this is a T1 fat saturated post-contrast image. So we've given contrast to try to get a better understanding of how much of this tumor is viable. Everywhere that's bright on this particular sequence, we expect to represent viable tumor. And again, we see that this tumor is pretty homogeneously enhancing, with the exception of these fibrous septae that are dividing some of the lobules. So this patient had actually had a total resection of the tumor in the past, to the point where there was no detectable disease. He had intraoperative radiation therapy as well, but the tumor grew back. And despite different chemotherapeutic agents that were tried, it grew again to be this size. So we brought him for focused ultrasound, and you can see the very dramatic treatment effect after the focused ultrasound. So again, this is a post-contrast image, and if there are areas of viable tumor, we'd expect those to be bright, but instead we see this central darkness within the tumor and just this minimal rim of enhancement of bright signal at the edge, consistent with a really nice treatment effect. So again, these are axial images. The patient is sort of laying down on his belly, or maybe a little bit on his side. This is the ultrasound transducer itself within the table. And this is a gel pad that we use to make sure that the acoustic energy flows seamlessly into the patient. Now, that's what we normally are aiming for when we're doing these focused ultrasound treatments. But I want to show you an interesting case when things didn't quite go that way, but which really got me started thinking about the potential of immune response effects for patients with soft tissue tumors in focused ultrasound. So this is a 25-year-old woman with a history of a left flank desmoid tumor. This is another axial image at the level of the lumbar spine, sort of the upper portion of the lumbar spine. So you can see this is part of the vertebral body that we're slicing through. This is the more posterior aspect of the spinous process. There's a little hint of kidney right there, and some bowel in the more anterior aspect of the abdomen. And here's our tumor. So it's in the subcutaneous fat overlying the paraspinal musculature on the left side of the patient. And you can see that this seems like a tumor that would be relatively easily accessible with focused ultrasound. There's nothing in the way between the skin and the tumor target there. So we brought the patient in for a focused ultrasound treatment. This was many years ago when we were just getting started with treatments, and we're probably fairly conservative in our approach, being mindful that sometimes focused ultrasound energy can continue to propagate past the target, and we have structures in the far field that we wouldn't want to injure, like bowel. So we might have used less energies than we would these days. And you can see that the treatment effect was somewhat different from what I showed you in the case of that 7-year-old boy. We don't have that sort of central darkness within the tumor that we typically are aiming to see. So it seemed like there was still some viable tumor centrally, and a bit of new haziness or fuzziness to the margin of the tumor at the edge. This was a young patient. She was doing well. The tumor wasn't growing, so we decided we would watch it and get a sense of what was happening over time. At 4 months, you can see maybe this area of fuzziness at the periphery of the tumor was starting to increase a little bit. Then more dramatically so at 6 months after the treatment, and we see additionally, in addition to that peripheral haze, now we have that central area of enhancement of brightness that we saw all along. That seems to be disappearing, for lack of a better word. And then at 18 months, the entire tumor seems to be sort of slowly fading away. And when I'm not doing focused ultrasound treatments, I spend a lot of my time evaluating patients with all sorts of musculoskeletal tumors across the body. And oftentimes I'm asked to evaluate the response to treatments. And typically tumors will either sort of uniformly grow or uniformly shrink. They don't really ever do this kind of disappearing response that we're seeing here. And this made me think that perhaps I was watching a focused ultrasound related immune response effect. So maybe the treatment that we did sort of helped the body to recognize the presence of the tumor, and leading to this clearing of the tumor in this very unusual fashion. So that brings us to the topic of immune response effects of focused ultrasound and the large body of literature that exists that has helped us to understand these relationships that we hopefully can exploit to improve cancer therapy going forward. So we know that in many focused ultrasound treatments, the goal is sort of thermal ablation. We're essentially kind of thermally fixing the tissue, leading to this coagulative necrosis, which does have some immune response effect potentiation to that process. Antigens get released and picked up by the immune system, and that can lead to an immune response. But we know that there are other aspects, other mechanisms of focused ultrasound that can also potentiate the immune response. So these include mild hyperthermia and mechanical destruction of tissue with either sort of a histiotripsy approach or a pulsed focused ultrasound approach. So we know that in the setting of thermal ablation, like I mentioned, that's going to lead to release of proteins, antigens, in addition to heat shock proteins. Hyperthermia will also lead to release of heat shock proteins and increased perfusion. Histiotripsy, and by that we mean using high intensity pulses to mechanically homogenize tissue, leading to sort of a tissue liquefaction, is going to perhaps even lead to a stronger level of immune response with the release of intact cellular proteins that haven't been so thermally damaged. Pulsed focused ultrasound with either mid-pressure pulses or with or without microbubbles can lead to release of various immune factors, DAMPs, various cytokines, cellular adhesion molecules. We also know that blood-brain barrier disruption is something that can be achieved with focused ultrasound, low pressure focused ultrasound, which can help to enhance permeability and upregulation of cellular adhesion molecules. So when you think about the steps in the response of the immune system to the presence of a tumor, it's really exciting to think about all the different areas where focused ultrasound might help to upregulate these steps. So you can look at the cycle here of tumor cell antigen release, leading to capture by circulating lymphocytes, presentation in the draining lymph nodes, priming and activation of the immune system, leading to increased circulating tumor-specific T cell recruitment, and then infiltration into the tumor and hopefully elimination of the tumor from the body. We can see these multiple steps along the way that we think focused ultrasound might help to stimulate this particular activity and hopefully help to improve patient outcomes. A lot of the excitement around focused ultrasound in the context of immune response effects is related to the fact that we know that immunotherapies are a class of medications that have really shown such incredible potential to generate very, very strong levels of response in patients with a variety of malignancies. And one of the immunotherapies out there that is particularly exciting are these checkpoint inhibitors. And the way these medications work is they rely on the fact that various tumor cells are known to interact very directly with the immune system. So there are tumor cells out there that have antigens, so proteins that are presented on the surface of these cells. And these antigens are trying to do something fairly pernicious. They're trying to convince the immune system by this interaction with a receptor on the surface of the T cell, convince that T cell to leave it alone. Don't eat me, stay away from me. And so what this new class of medications has been able to do, either by blocking things on the antigen side of things or on the receptor side of things, these PD-1 and PD-L1 inhibitors have helped to turn off that signal that the tumor cell is sending out there to try to protect itself, and led to the T cell now being able to respond and attack that tumor. Now, the challenge with these medications is that when they work, patients can have a great response, and in some cases even complete responses, very dramatic responses on imaging to their tumors all over the body. But they only work oftentimes maybe 20–25% of the time across a range of cancer therapies. So if there was a way that we could use some additional procedure, some additional adjuvant to improve or increase the number of patients who would respond to this particular therapy, that could be really dramatic in the world of oncology and taking care of patients with cancer. So just to emphasize, what we're really focused on here is this idea of combining focused ultrasound with immunotherapy and hopefully improving the efficacy of these PD-1 inhibitors that have shown such tremendous promise. Blood-brain barrier opening is another really exciting potential use of focused ultrasound, but I'm going to focus on this first concept. So our feasibility study is really designed around that first concept and really focusing on this particular soft tissue sarcoma that which we see quite a bit at my institution, which are undifferentiated pleomorphic sarcomas. So this is the fourth most common soft tissue sarcoma. Common sites include the lower extremities and the upper arm, retroperitoneum, viscera, and the head or neck. And 5-year survival is varies a little bit depending on exactly where the tumor is located within the body. So probably around 48 or 50% for tumors in the head or neck, and up to 77% for tumors in the trunk extremities. So clearly quite a large fraction of patients that still need improved treatments for this type of malignancy. Here's a nice example of an undifferentiated pleomorphic sarcoma. We're again in the pelvis. So here's a coronal image through the body. These are the sacroiliac joints. This is actually a little bit of the spinal canal. And here's the hip joints here. We're seeing the proximal femur. And you can see this large heterogeneous tumor in that subcutaneous fat layer between the fascial margin of the deep musculature and the overlying skin. You can see it's actually tenting the skin, and there's some surrounding edema consistent with a little bit of an infiltrative component. So these are fairly aggressive tumors. Here again, we're seeing on the axial image, it's just a little bit lateral to the femur there and pushing out that skin laterally. Now, these tumors are very difficult to control. Our standard approaches include surgical resection, radiation, and chemotherapy. But as I referred to on the last slide, there are a lot of patients who don't do well despite these different conventional therapies. So there's been some excitement over the last few years in terms of the possible role for immunotherapy in treating patients with undifferentiated pleomorphic sarcoma. And there are a couple of reasons for this. So for one, there's a study of the expression of these particular antigens in these patients, and it was found that there was a high level of PD-L1 expression across a high percentage of UPS cases. Additionally, there is a study of using one of these inhibitor immunotherapy type medications in a range of soft tissue tumors, including 10 patients with UPS, and 4 out of the 10 patients demonstrated an objective response, including 1 complete response, which might not sound like a lot, but when many conventional chemotherapies are at best able to result in maybe a 10% or 15% response rate, this is a really exciting number to see. Follow-up of those patients show that the cohort within this study met their primary endpoint of an objective response. 23% of the patients had a successful response. And additionally, in terms of looking at some of the histology specimens, the PD-L1 expression and lymphocytic infiltration appear to correlate with survival. So all reasons to think that if we could try to get the immune system to be a little bit more cognizant about the fact that there is this tumor present, we could maybe make a real impact in terms of patient survival and long-term outcomes. So that brings me to the feasibility study, which we've recently launched at UCSF. And the idea is to first evaluate the safety of pre-resection focused ultrasound, but really more the focus is to understand what is its potential for effectiveness in promoting immune response effects, with a hypothesis that focused ultrasound is going to be safe and patients will demonstrate increased circulating immune response biomarkers and increased leukocytic tumor infiltration following the focused ultrasound treatment. So to do this, we're going to do limited focused ultrasound in these patients about 1 to 2 weeks prior to their surgical resection, and ablate a small spherical target that we know we can ablate very safely based on our long experience with other soft tissue tumors. Primary endpoint here will be safety, making sure things are safe over 4 weeks. That has to be the case whenever we're doing a new FDA indication. But really, we're focused on these secondary endpoints, trying to understand what are the changes in the serial serum biomarkers from 1 week prior to focused ultrasound to 1 week following the focused ultrasound, doing an array of flow cytometry panels and calculating the change in different immune cell populations. And then we're also going to do immunohistochemistry analyses with the resected surgical specimen, trying to understand what are the changes in the immune populations and tumor specimens, looking both sort of just adjacent to the area that we ablated and more remote areas within the tumor itself to get a sense of what's happening with regard to immune cell infiltration. So here's just a basic schema that sort of sums things up. So we're trying to enroll 20 patients. Again, we'll take the blood sample before and after the focused ultrasound treatment. Patients will go on to have a resection and we'll do a tumor specimen analysis. And then we'll check in with the patients for a few weeks afterwards to make sure there were no adverse events. Now, unfortunately, we had been all set up to get this study going earlier in the spring, but of course, COVID hit and disrupted this as it disrupted so many aspects of our lives right now. But fortunately, we're able to move past that in recent months and get this study up and off the ground, so actively enrolling patients currently. The idea here in the long term is that if we can show that focused ultrasound does indeed improve immune response effects in these patients, you can imagine a day where a patient initially presents with this tumor. They get started on one of these checkpoint inhibitor type medications. They go on to have a focused ultrasound treatment to try to boost the efficacy of this medication. Then they'll go on and continue to take their immunotherapy, which hopefully is a little bit more impactful. And then maybe along the way, if they need an additional boost to the immune system, they could be brought back for additional focused ultrasound treatment. So I think that's the long-term vision and really exciting possibility for these patients in the future. So in summary, immune response effects of focused ultrasound offer incredible new treatment possibilities for many diseases, including soft tissue tumors like undifferentiated pleuromorphicsarcoma. And understanding how focused ultrasound can provide synergy with medical therapy will be one of the next great leaps forward in our field. Thanks so much for your attention, and I'll hand things over now to Dr. Ghanouni.
Hi, everybody. Thanks very much for participating today. Thank you to Dr. Bucknor for an excellent talk and a nice segue to what I'll be talking about today. Audience, thanks so much for joining us today to participate in this. My name is Pejman Ghanouni. I'm a member of the Body MR division here at Stanford, and today I'll be representing our minimally invasive MR Interventional Center, which I've helped to establish and direct, talking about some of the technical advances in MR focused ultrasound applications. My disclosures: I serve on the medical advisory boards for Insightec and Sonalisense. Our minimally invasive MR Interventional Center, or MIMRIC, is a group now that's grown to 4 faculty members, program leadership within the Stanford, physicists and PA nursing staff, schedulers, trained MR technologists as well. A real solid group of people that are all motivated towards minimally invasive MR guided interventions here. The vision of the program really circles around MR detection. And so the idea is, with early detection, thanks to improved MR imaging, this allows for early intervention. And early intervention avoids the morbidity of intervening late, and also avoids some of the risks of metastasis. So the concepts basically are this triangle where high quality diagnostic MRI can lead to ultimately MR guided tissue biopsy and pathologic diagnosis, and MR guided therapeutic intervention, and then back to diagnostic MR for follow-up. An example of MIMRIC's vision is in its application to prostate cancer. So to put things in context, 1 in 9 men will develop prostate cancer in their lives. Yearly incidence is about 110 per 100,000, which means that this year about 190,000 men will develop prostate cancer. 75% of those are going to have localized disease. And if you estimate, about a quarter of those men will have intermediate risk Gleason 7 disease. So based on the histology, that leaves about 35,000 men that have this intermediate risk category, which I'll talk about a little bit more. So if even a quarter or a third of those men are candidates for focal therapy, that's a large number of people that could benefit from this approach. So what do I mean by this? What's the concept behind this? Well, so it first starts with detection by MRI. So, we have a tool now with MR, with multiparametric MR, where we can see the leading edge of cancer, the index lesion, very well on T2 weighted imaging, diffusion weighted imaging, and post-contrast imaging. These combinations of imaging sequences can point us in the direction of what is the most worrisome lesion within the prostate gland. This can lead to MR-guided biopsy. Obviously, most of the time this is done by the urologist using a transrectal ultrasound-guided approach, often nowadays fused to those MR images I just showed you, but it can also be done directly in bore by MR, where we can be confident that we're placing our needle exactly into the most suspicious lesion that was seen on MR. And of course, this then leads to the histologic categorization. And the group of men that I'm talking about are those that have locally confined intermediate risk prostate cancer. These are men for whom the risk of metastasis is probably too high to put them into an active surveillance category. This is maybe more appropriate for the lower risk Gleason 6 disease, although I will say that many of the men in this category do end up progressing and needing some kind of intervention. The disease is probably not risky enough to warrant whole gland therapies with their risks of incontinence and impotence and the toxicities associated with radical prostatectomy or radiation therapy. So there's this middle ground in which focal therapy really has a role to play, something where we can treat a disease that is too aggressive to just watch, but not so aggressive to warrant whole gland therapy. Now, I should say that my approach in my experience is with MRI and with FUS. There's advantages obviously to both, and that's why I'll be talking more about them. But I'm agnostic as to which methods will be most effective. I think we still need to investigate this. Will it be focused ultrasound, histotripsy, MR guided, ultrasound guided? I think all of these have a role to play. But again, my experience and my bias is towards MR guidance, as you'll see. So that being said, this is an example of a patient that had a focal Gleason 7 MR visible prostate cancer that underwent transrectal focused ultrasound ablation. You can see what's been done is that the area around the cancer plus a margin of normal tissue has been ablated. We were able to avoid the neurovascular bundle, able to avoid the urethra. This was an effective approach where subsequent biopsies at 6 months and 2 years showed no residual disease at the treatment site. And the morbidity associated with this focal approach is such that the patient basically leaves the treatment area the same day with a Foley catheter that gets removed within the week and is able to quickly return to normal activities and most importantly has normal function. Now, with MR guidance, what we can see is some of the challenges behind these focal approaches. So this is MR thermometry that's being utilized to monitor the treatment area. And what we can see is as the thermometry is going, we are ablating a portion of the prostate. And the red zone is tissue that's reaching 70 degrees Celsius. And as you can see that different parts of the prostate within the defined region of treatment are responding very heterogeneously. Portions of the prostate reach a very high temperature and portions are inadequately treated during this first sweep. Well, what that allows us to do, of course, is to then measure the thermal dose, which is seen here in this dark green area. This is a high thermal dose zone. The kind of grayer area around it is a lower thermal dose. But you can see there's portions of the treatment area, which is defined by this orange polygon. There are areas within that treatment zone that don't reach thermal dose. Well, what we can do now, of course, is we can recontour those areas that did not reach adequate treatment temperatures, and we can retreat those areas. So thermometry is critical to accounting for the inherent heterogeneity of the tissue. By doing this, we're able to see what we've effectively treated and what wasn't effectively treated the first time and allow us to retreat that area. That's something that's unique to MR right now, that we're able to see and measure that thermal dose and make sure that we're able to treat safely. We can monitor the rectum and avoid high temperatures within the rectum. And we can also monitor where we're trying to treat and make sure that we treat those areas safely and effectively. And we're getting this information both intraoperatively, but remember that we also have a lot of preoperative information that we could use for planning. So we have information about the T1 and T2 properties of the tissue and the tumor itself, the diffusion parameters, the perfusion parameters. All of this information helps us to identify the suspicious area and biopsy it, but it could also go into our treatment plan. And that's something that's lacking right now, is that we're not incorporating our preoperative imaging, what we know about the tissue and its tissue properties, to design the target, to design that treatment plan. Ideally, what we would do is take this information ahead of time, and when we're targeting that tissue, we would know which portions of the prostate are going to respond adequately and which portions may need more energy, which portions may be very sensitive to heat and need less energy to reach thermal dose. we should be able to incorporate this into our treatment plan from the beginning and avoid the need for re-sweeping through that area again and again in order to make sure that we're getting an effective treatment. This is by no means unique to prostate. I talked about prostate cancer with T2 and diffusion and post-contrast. Dr. Bucknor has shown desmoid tumors, and as you can see, these tumors are incredibly heterogeneous in terms of their T2 and T1 and post-contrast properties. All of this leads to areas within the tumor that are very, very sensitive to heat. These darker areas on T2 tend to be more fibrous. They absorb the ultrasound energy very efficiently, whereas the more heavily perfused areas need much more energy in order to get adequate temperatures and thermal dose. Again, we should be able to incorporate all of that information up front and have smarter treatment plans than we currently do. And I think that's an area for active future development. This is certainly not unique to soft tissue tumors either. And the challenge of patient-specific treatment is something that has been ongoing in the brain. And so, of course, we've been taking various modes to try to understand and model how ultrasound traverses the skull. You can see this image of all the varieties of CT scans. These are CT scans from the various patients that we were screening for our thalamotomy treatments for essential tremor. And what we're trying to do is figure out how do we get a patient-specific targeting approach, accounting for the variation in skull parameters here. Right now, that patient specificity comes from an awake patient in which we're able to monitor their treatment response. We do various neurologic tests while we're treating the patient, and that gives us the ability to adjust our targeting, to move the focal spot around and try to eliminate tremor while minimizing any side effects. But again, this variation in skull properties could be utilized for better initial planning. Now, what's lacking in some of this, of course, is better integration of some of the targeting tools, improved thermometry, and again, accounting for some of the patient-specific features for better spot shaping. So these are some of the things that I'll talk about. What do I mean by that? Well, look at these maps. These are a map of the 1,024 elements in the Inside Tech ultrasound transducer used for brain treatments. And the different maps here represent the skull score, the so-called skull density ratio for each of the different elements. This is basically looking at the efficiency with which individual elements can reach the target within the center of the brain. And so you can see, if we look at the right temporal region here, these elements are relatively efficient. The elements along the vertex are relatively efficient. Elements more anteriorly within the skull have a difficult time reaching the target. The same thing when we try to account for the external angle. Many of the elements along the left anterior portion of the skull are going to be reflected because of the incident angle. And this is the application of a mask, to the elements, turning off elements from the temporal region in an effort to try to concentrate and minimize smearing of the thermal energy around the target. All this information is somewhat kind of crudely integrated right now, mostly in my head, to try to figure out how do I get an ideal target shape and spot zone at the region that I want to treat. All of this information is available ahead of time, however, and could be more intelligently integrated in a spot shaping paradigm in which we end up with a much more focused and much more targeted approach towards treatment. Now, some of the challenges, of course, have to do with intraoperative monitoring. So what limits somewhat our ability to improve targeting is the fact that right now we're doing single slice thermometry. So we're looking at single slices in sagittal and coronal and axial when we're doing the thermometry during treatment. And what that leads to, these are images now after treatment, and you can see the thermal ablation zone within the left thalamus here. And on this axial image, it looks nicely confined within the thalamus. Coronal and sagittal images, however, reveal a small zone here that's been circled that extended a little bit anteriorly and a little bit laterally to the regions that were being imaged on these single slices. And so this is a limitation of the current single slice thermometry. With improved imaging tools, improved coils, improved sequences, we can capture this information up front, improve the targeting, and improve the safety of the procedure. So thankfully, new coils have been introduced at 1.5 Tesla and now at 3 Tesla. These are images from the standard body coil at 3 Tesla and now with the new head coil obviously dramatic improvement in our ability to visualize the thalamic and surrounding structures in all three planes. You can see the dramatic improvement in the thermometry. This coil should lead to dramatic improvements in our ability to visualize the target as well as to monitor the treatment zone. It should also allow us to improve some of the targeting methods that we use. Currently, we're utilizing some approaches now where we segment the thalamus and use segmentation tools that have been described by Jakob et al., as well as by my colleague, Dr. Brian Rutt, where we segment the thalamus and look for the VIM nucleus within the thalamus and use that as a targeting approach. You can see how well the VIM here in red, how well the targeted lesion in this patient who was successfully treated by FUS, how well that overlaps with the predicted region of the VIM within the thalamus. So obviously these tools can be used preoperatively as well, again, with improved imaging that allows us to see and segment the thalamus more efficiently during the treatment itself. With these new coil, we can improve our intraoperative monitoring now by, rather than doing single slice thermometry, we can either do volumetric or multi-slice approaches where we can much better monitor the treatment zone as well as the region around the treatment zone. Certainly this should improve safety, but it will also give us a better idea of the actual spot shape. Some of these approaches were described by Marks et al. There are many other approaches that are in the works. This was a multi-slice approach. There are volumetric approaches, as I mentioned, as a way to monitor the thermal spot. All of this, again, depends on having improved imaging through the coil. Now, I want to mention as well that when we're doing this treatments, whether in brain or soft tissue, there's a concern when there's repeated treatments, and this is probably more important with some of the soft tissue ablations that Dr. Bucknor talked about earlier. Often in those cases, we're doing 100 sonications. And so, of course, the assumption is that between sonication 1 and sonication 2, the background temperature goes back down to baseline. But what really happens is we don't quite get back down to baseline. And although the region in the surrounding tissue may not reach a thermal dose within a single sonication, by repeatedly sonicating and not having the tissue get back down to baseline, we're basically building up heat in the surrounding tissue over and over again. And this results in a cumulative dose. We miss some of this when we're doing this in a slice by slice and sonication by sonication approach. By having better imaging, we can look at a volumetric acquisition of thermal dose, keep track of how each voxel is doing over time, and see which voxels can reach thermal dose, not by a single sonication, but by multiple individually sublethal sonications, but that ultimately reach thermal dose. This obviously would help us to more adequately treat tumors. This is an example of a desmoid tumor within the breast, where you can see an individual sonication is reaching thermal dose within the targeted region. You can see the thermal map here predicts ultimately that we missed portions of this tumor, but in actuality, if you look at the non-perfused volume after this, the entire tumor was adequately treated. And we've learned through time and experience that we don't need to necessarily get every voxel up to thermal dose in order to see that that area is ultimately ablated. But some of this just reflects the fact that portions of this tissue are reaching a cumulative dose that isn't being captured by individual sonications. The risk to this, of course, is in this other example of a desmoid tumor in the right hip. When we ablated a portion of this tumor, we were able to avoid the portion near the sciatic nerve, and you can see that the portion that we targeted was well ablated. All of this region was predicted to reach thermal dose, but what wasn't predicted to reach thermal dose was this area in the near field in the gluteal muscle. And as a result of repeated sublethal sonications, a portion of that gluteal muscle also ended up getting ablated. With better intraoperative monitoring, with better volumetric imaging, thermal imaging, we can keep track of this over time and avoid some of this near field. You know, the risk of this isn't just in some of the near field damage to the muscle, but also to the skin. And so we see here some of the consequences from these sublethal sonications at the skin. You can have patients that have some erythema, like a first-degree burn. Here's examples of blisters, especially around surgical scars, second-degree burns, and you can have even third-degree burns, especially when you're trying to treat through fat, where obviously the thermal monitoring is poor, and you can result in third-degree burns. So these sublethal sonications do have a strong impact on our patient treatments. Now, one of the ways that we tried to avoid this in the past is basically by cooling the skin. And unfortunately, the body system does not have an integrated cooling system with it. And so we essentially tried to introduce what's the equivalent of a camp shower. So basically a bucket of ice water that was basically dripping into the area around the treatment zone in an effort to keep the skin cold. This helped. It helped to reduce the incidence of some of the burns, obviously. But as you can imagine, it's not very elegant this approach. And so as a plug to the Focused Ultrasound Foundation, they shared our vision here for an approach that would improve safety and help to fund a project that Allison Payne and her team at the University of Utah carried out in collaboration with our team, where they've built a chilling device that we can integrate into our treatment. Here's an example of this balloon that circulates cold, degassed water. Patients would now lie on top of this rather than on a gel pad. And here we are testing that in a pig model, showing our ability to now treat very close to the skin. And here we've now integrated it into our desmoid treatments now, where the patient, rather than lying on the gel pad, is lying on this cooled balloon. And what that allows us to do is actively cool the skin and avoid some of those near field problems that I showed you in the past. A simple improvement, but it's these kind of simple improvements, improved coils, improved cooling systems that allow us to get better treatment planning up front, better intraoperative monitoring during the treatment. Now, moving to pancreas, I think this is an area where obviously with ultrasound-guided focused ultrasound approaches, we've seen exciting results there coming from East Asia, from the teams in Barcelona as well. But what and of course with MR-guided focused ultrasound, Dr. Napoli's team in Italy have also shown the feasibility and some exciting results there. What we want to be able to do though, in this area, you can see that real estate is very expensive, right? We're trying to target a tumor in the pancreas, but we have liver, bowel, vessels, all around. And so we need to have better imaging of the tumor target as well as of the surrounding anatomy and of thermometry. And so we've collaborated with Anna Arias and Mickey Lustig at the University of California, Berkeley. These are acoustically transparent shoot-through coils. These are coils that can be placed between the gel pad and the patient, and the ultrasound beam goes through the coil without being attenuated significantly. And what it allows us to do is dramatically improve our imaging of the target as well as of our thermometry. And this is an exciting new application that we hope to integrate into our treatment. I'll end by talking about how I hope to integrate some of these, the coil as well as the cooling system. And this is kind of a follow-on to what Dr. Bucknor was talking about. With focused ultrasound and immunotherapy, specifically targeting pancreatic ductal adenocarcinoma. So what we know is that pancreatic cancer can be treated with focused ultrasound, but we know that this is really a tough nut to crack. And people have tried various immunotherapy approaches, and what we've seen is limited efficacy when monotherapies targeting CTLA-4 or PD-1, PD-L1 checkpoint inhibition have been used. Various other approaches using vaccines have also had limited efficacy. But why is this? It's a difficult cancer because there's limited neoantigens, and also because the tumor microenvironment is very desmoplastic. There are few, excuse me, there are few tumor cells, few immune cells in the area, and the serous reaction that the tumor excites around it limits the access of the immune system to the tumor. So when we see that monotherapy hasn't worked, of course, if you can look at clinicaltrials.gov, and if you type in immunotherapy plus pancreatic ductal adenocarcinoma, you'll see that there's many approaches that are trying to combine immunotherapy with chemotherapy, with vaccines, radiation, and even electroporation. And what we're going to do, what we've done is we've started a study now where we're combining focused ultrasound, ultimately with the goal of combining FUS with immunotherapy. This is building off of work from Professor Ferreira here, as well as others that have shown that when you combine focused ultrasound, first you can see in this pancreatic cancer cell line that after focused ultrasound, not only do you get an ablated zone, but in the region around the ablated zone, in the treated rim that becomes somewhat hypothermic, you can see an infusion of immune cells. So we have preclinical data that supports the idea that the combination of focused ultrasound, that the introduction of focused ultrasound can excite an immune response around these tumors. And of course, we have data from her lab and others showing that when we combine ablation plus immunotherapy at the treated zone, as well as at contralateral tumors, we can excite not only a tumor response within the tumor, an anti-tumor response within the tumor, but also in an abscopal response in an untreated tumor. And the combination of ablation plus immunotherapy is better than immunotherapy alone. And so As a final plug, I'll just say that the Focused Ultrasound Foundation is sponsoring a study. We'll start off, much as Dr. Bucknor described, with an approach looking at feasibility and safety of ablation, and we'll also be looking at biopsies of the pancreatic cancer before and after ablation, looking for changes in the immune cell population, both in and around the tumor as well as in the blood, and looking if the basis of that. The results of that study will then lead to a second study in which we directly introduce immunotherapy to these patients in combination with FUS in patients that have advanced pancreatic adenocarcinoma. So I want to thank the audience for their attention. Special thanks to the Lockhart family for their generosity and the recognition for our work and the potential of our future work. Of course, the Focused Ultrasound Foundation for hosting the webinar, and to the MIMRIC team here at Stanford that have been a key part of our success going forward. Thank you again.
Great, thank you both. I think we're gonna get on camera and answer a few questions that we've gotten. So thank you both for excellent presentations. So I wanted to start with Dr. Bucknor. When would you recommend a partial ablation with the intent to induce an immune response versus a total tumor ablation? And do you expect that immunotherapies would synergize well when the entire tumor volume is thermally ablated?
Yeah, so I think that in terms of complete ablations, we do that whenever it makes sense in terms of the patient's clinical care to totally ablate a tumor. So oftentimes for a desmoid tumor, if there's a way to completely ablate it, that's what we'll do. Partial ablations we do if that's not feasible, and if it seems like the patient might have some significant benefit from a partial ablation. But in the context of the trial, everything that we're going to be doing for the trial for that particular tumor, undifferentiated pleuromorphicsarcoma, is going to be a partial ablation, in part because we know if we were to ablate the entirety of the tumor, it'd be difficult to get a sense of what's happening in terms of the changes of the immune cell population. So it's specifically part of the design of the trial that we want to do a partial ablation for the UPS patients.
Okay. And is that trial, does it include pediatric patients or any of your work?
That trial does not include pediatric patients, and that's simply because it's a soft tissue sarcoma that doesn't occur in pediatric patients. Okay. But we do treat pediatric patients with focused ultrasound, in particular patients with desmoid tumors or patients who have another benign bone tumor known as an osteoid osteoma. We have an active trial treating patients who are younger in those situations.
Okay. We've gotten questions for Dr. Ghanouni. You spoke about the technological difficulties of brain treatments and how new approaches are improving this process. Outside of the brain, what are major exclusion criteria that are preventing patients from being eligible for focused ultrasound treatment? And do you see that changing as the technology progresses?
So this is actually kind of a nice segue from the question to Dr. Bucknor. I mean, when we talk about patients in terms of partial treatment, sometimes it's outside of our control. We know going in that we will not be able to treat this tumor completely because of its proximity to the skin or its proximity to nerve structures that are critical and that we can't ablate. You might ask, why do we bother in those cases? And it's because of data from our preliminary work that we published showing that partial treatment in desmoid patients, many of these patients have pain as their primary problem. And we see that even with partial treatment, we're able to significantly improve their pain symptoms. So we ablate what we can, we improve their pain. And then when the tumor starts to regrow, we can go after it again, or we can hope for some kind of immune response that might help us with some of these tumors in terms of the control. Those same features are what limit access, I would say, to focused ultrasound. Tumors that are very large, tumors that are very close to the skin, tumors that have infiltrated close to critical structures are very challenging to treat. Scars from prior surgeries can be prohibitive as well, and make it such that we can't gain acoustic window to access the tumor. The cooling system that I presented, I think will help with some of these cases in which tumors are close to the skin, and with large tumors. With these larger tumors, just the cumulative effect of many sublethal sonications is dangerous, as you saw. And by actively cooling, we can help to minimize some of the off-target effects, and hopefully open access for these patients to focused ultrasound as well. I think
So
with
another,
targeting approaches, though, if I can, sorry, with better targeting approaches, understanding how to target near nerves, for example, how to avoid high temperatures in those areas would dramatically improve our confidence in the treatment. As it is right now, we start off with a treatment plan that's designed for uterine fibroid. And through our own experience, sonication by sonication, modify the treatment parameters to optimize the treatment. Obviously, there's much smarter approaches available to us now, whether through AI or taking advantage of what we've learned so far.
well, it's interesting you bring up AI because I did just get a question about that. And do you think AI will soon be able to help in the planning of the treatments to both optimize the efficacy as well as reduce some of those side effects like the near field heating or nerves and things? So maybe for both of you, if you want to comment on that, the role of AI maybe in the future.
Matt, do you want to?
Yeah, sure. Yeah, I think there's incredible potential with AI. I'm not sure what the exact timeline will be, but you can imagine that if we can pool our collective experience with, you see this tumor, it's this hyper intense, you put in this energy and this was the treatment result. And if you sort of aggregate all of that data, you can imagine some sort of algorithm would be able to give a more accurate prediction of what's the variability and the energies that you're going to need a priori before you start the treatment, and come up with a really tailored treatment plan, pixel by pixel, with what you're seeing in the tumor. So I think that is a really exciting area of potential research.
I would say it's an essential next step. We are, every time I do these treatment plans myself, every time I try to integrate my experience of how the beams are going to penetrate the skull in this particular patient's case, I'm begging for a computer algorithm to come and take all of our experience, not just at Stanford, but from around the world, and help me to target more efficiently, more effectively, more safely at that area. Right now we have, as you saw, a spot in the brain that's oblique in every direction, and it shouldn't be that way. We should be able to take the patient's CT scan or MR images or both, and shape that spot to be exactly the shape that we want it to be, to contour it to the shape of the VIM, for example, or the other targets that are being utilized now in the brain. I think that's an essential next step in the brain, outside of the brain. We're really begging for the introduction, and there's adequate data now, I think, out there to start applying some of these algorithms and training them to better improve our treatment plans.
Great. A couple of little more general questions. What do you think is the most exciting new clinical oncology application for focused ultrasound? You both talked about some that you're working on, but what do you see as the real exciting application in the future?
Matt, you want to go again, or?
Why don't you go first?
Okay. Well, there's obvious excitement about targeting within the brain. And so certainly areas where we're either ablating and/or opening up the blood-brain barrier to deliver chemotherapeutics in the brain are an obvious area of excitement. Everyone's aware of them. One of the reasons I brought up prostate cancer, though, is to put things to some extent in context. The number of patients that we're talking about with prostate cancer is enormous. And so the opportunities there to impact a large number of patients, by definition, is very large as a result, even though only a subset of those patients may qualify for focused ultrasound treatment. And the other thing to keep in mind is that most of these patients with prostate cancer that have this intermediate or low risk disease, they're going to live a long time with that disease. And so having a way that we minimize their morbidity while still effectively treating their cancer is going to have a significant impact if you look at quality adjusted life years. If you start thinking about not just the morbidity locally, but also extend that over the next decade or 2 decades of that patient's life, avoiding urinary incontinence, avoiding impotence, but still effectively treating their cancer. So, personally, I'm very excited about the ability to utilize MR-FUS for prostate cancer, and I'm looking forward to being able to offer that. I know our patients are very interested in it as well. When we were doing that as part of a clinical trial, they were beating down the doors, honestly, because the other options are either to watch a cancer, which many people don't like the idea of sitting there watching a cancer, or to potentially expose themselves to radical therapies that they know are very morbid.
Yeah, I would agree with that. I'm very excited about the possibility of using this technology in cancers where there are just so many patients out there that need better options. And prostate was the first thing that I thought of. I think that's really high on the list. And again, as Dr. Ghanouni, for these sort of intermediate cancers, it seems like it's such an attractive and powerful solution. I also think about breast, because there's so many patients with breast cancer, and it's an easily accessible target. And I know that there's studies that have been launched looking at combining focused ultrasound with immunotherapy in the setting of patients with advanced breast cancer. I think there's a study that the foundation is sponsoring at the University of Virginia, if I remember correctly. Yeah. And so the potential for having an impact on both of those conditions and the number of patients who are suffering with those diseases is just enormous.
Great. Well, I think that is all the questions that we have, and we're just a couple minutes before noon. So if you guys want to have anything else you wanted to say, that's fine. Otherwise, we'll just sign off, and I'll thank you again for the great presentations today. And again, congratulations on the honor of winning the Lockhart Award this year. So very pleased. Okay, so this concludes today's webinar. And for those of you who maybe didn't ask a question or think about something later on, please feel free to visit our website, fusfoundation.org, or email us those questions at info@fusfoundation.org. And thank you all for joining us today, and stay tuned to our newsletter and website for invitations to future webinars. And for those who have not yet registered for our symposium, which is coming up next week, you can register at any time, and you already have access to a lot of great on-demand content right now. So we hope to see you online next week at our symposium. Thanks again. Have a great day, everyone.